At last, talking about the management of the patient who has not yet developed cardiac tamponade but has acute pericarditis and pericardial effusion, you would hospitalize the patient and then monitor his or her pulse and see if there is backslide showing, and if it is showing then you would do serial echocardiography of the patient. The condition of the patient is not getting better, then the doctor should do pericardiocentesis. Before doing pericardiocentesis, he should confirm that the patient should not have aortic dissection or post MI free valve rupture, and see that the fluid is dark colored, meaning it is hemorrhagic and non clotting. If the fluid is bright colored and clotting, then the treatment is not going the right way. Pericardiocentesis is important because if we see pressure volume relationship, then it is curvilinear, meaning if 100 ml of blood is leaked out or taken out of the body, then there will be too much relief, meaning the too much decrease in the pressure of the heart. And if the condition is still getting worse and there is recurrent tamponade or localized tamponade, then surgical drainage can be done in subxiphoid region, making a pericardial window or pericardioplural fistula in left pleural cavity of the body. Doctor can also do fluorodesis in order to increase fibrosis and removing pericardial cavity of the heart. In the terminal stages of the disease, pericardiectomy is done to remove pericardium of the heart, which can be done through usual ways or through balloon pericardiectomy, which is a new technique.